Thank you. Okay, well, first of all, I would like to thank the organization for this kind invitation. I'm speaking to you from Santiago, Chile, so I'm pretty far away and very excited to be able to show a little bit of the experience in the genetics or molecular testing in thyroid nodules that we've developed here in Chile and that has been growing. I'm a professor of head and neck surgery in the Pontificia Universidad Católica from Chile, and I also perform a lot of basic research in thyroid tumors, molecular biology. So my declaration of interest. And so I'm going to begin on a very well-known topic, which is the diagnostic uncertainty that we find ourselves with indeterminate nodules. In the previous talks, these nodules classified mostly of the Thy3 classification group, or Bethesda, in the Bethesda classification as Bethesda 3 and 4. And these cases overall have a risk of 25% of malignancy, and therefore diagnostic surgery is an option that is frequently recommended. And unfortunately, this translates into a very high rate of unnecessary surgery, exposing patients to the surgical risks, the lifelong hormonal supplementations, and the unwarranted costs. And therefore, genomic testing has emerged as an alternative to further improve the diagnostic accuracy for thyroid nodules. And these molecular tests overall have been designed in order to have a high negative predictive value, or in other words, reduce the risk from 25% to less than 5%, and thereby allowing to reduce the need for diagnostic surgery, or alternatively, by increasing the risk of malignancy from 25 to over 70%, therefore making it more reasonable to recommend a surgical approach. Just a few months ago, the new Bethesda category system was published. And as we know, for both Bethesda 3s and 4s, molecular testing has been recommended, or at least suggested, as an aid to the diagnostic process of patients with these categories. However, interestingly enough, for Bethesda 5, or suspicious for malignancy, they have included molecular testing, which for me, it was quite surprising, because the actual statement was it could help decide the extent of surgery, which in my opinion, there is no evidence to support that statement, because this is based on retrospective data and not prospective studies that show actually a benefit of doing molecular testing for Bethesda 5s. So in about a couple of 2 or 3 weeks ago, the European Thyroid Association clinical guidelines for thyroid nodule management was published, and mostly discussed these multi-analyte tests that use algorithms to classify thyroid nodules as benign or malignant, or at least their risk of malignancy. And probably many of you have read about the US marketed tests. The most known one is the Afirma test, and followed by ThyroSeq. And in this group of tests, a new test has been included, which is ThyroPrint, which is a test that we work with here in Chile. And I'll be giving you a little bit of more insight on our experience with this test. So I'm just going to take a few minutes to compare the validation studies of these different tests and look a little bit in depth to the quality of the evidence. And so in this table, what I'm showing here, the diagnostic platforms that are used by these tests, which are mostly have moved from PCR to NGS, where the ThyroidNext test uses both platforms. The Thyroid test uses only PCR. When you look at the design of the studies, all of these studies were multi-center. Not all of them were prospective, so that is something to keep in mind. And not all of them were double-blinded. That is, where the pathologist was blinded to the molecular test, and the technician was blinded to the pathology. And then the next criteria to look at the quality of the design of these studies is, were the correct patients included in the validation set? And you can see here that the correct validation set should have been only Bethesda 3s and 4s. However, some of these studies included patients that were Bethesda 5s, which initially for the validation set are not part of the intended use population. And you can see most of these trials had a very significant number of patients which was in line with the needed statistical power of these trials. A few years ago in my group, we performed a review of genetic testing with an interest to develop our own in-house test. And we performed a meta-analysis and review. And one of the exercises we performed is we mathematically modeled what would be the targeted sensitivity and specificity that you would expect from a molecular test in order to make it clinically useful. And so here in this graph, you can see in the x-axis is the disease prevalence or risk of malignancy, which in indeterminate nodules runs between a little less than 20 to 35%. And on the y-axis, you have the negative predictive value, and this graph, you have the positive predictive value. And so we modeled different sensitivities to make sure that minimum an MPV of 94 would be achieved. And we established that the minimal sensitivity you would expect to have is 90%. Similarly, for the PPV, we established that a minimum specificity would be between 70 and 80% to show a PPV greater than 60% in order to really move the needle in terms of the risk of malignancy and help aid the clinician with the decision. So when we look at the clinical performance of these different validation studies, you can see most of them have high sensitivity. So basically, these are, you could say, are relatively safe tests and have a variable specificity, where the Afirma test has the lowest specificity. The ThyroidNext shows the highest specificity. But in order to interpret correctly the predictive values, we have to look at carefully the cancer prevalence. And you can see there's variations here in the prevalence of disease. So what you see here is that the MPVs, or negative predictive values, are quite similar. So the post-test probability of malignancy in a benign call is less than 5%. And then the PPVs vary widely from 74 to 47%. But when you adjust it for across all tests for a pretest probability of 25%, the MPVs remain quite similar, and the differences are a little bit less on the positive predictive values. And the final comments I will make in terms of comparing these tests is how they perform in more challenging histopathologies. My apologies, this has not been updated to oncocytic cell. But the actual data available for these challenging subtypes is very low, and so we only have small groups of patients where overall they show that the sensitivity for her oncocytic cell carcinoma is relatively acceptable, and the specificity for the adenomas is also reasonably acceptable. And for medullary thyroid cancer, there's pretty much no real data to support any real conclusion and how they actually perform. Now I'm gonna switch gears here quickly to tell you a little bit about ThyroPrint, which is a test that was developed in our institution. The purpose of this test was to develop a test that would allow us to detect benign cases and rule out the malignancy, thereby helping us avoid unnecessary surgeries. And so this initial study was the gene discovery work, where we had two sets of FNA samples from indeterminate cases, all of which underwent surgical resection. So we had the gold standard, and using a neural network machine learning strategy, we developed a classifier that required to have a high sensitivity and specificity. And you can see the training set here had a 93, 91 sensitivity specificity, and in the independent validation cohort, we were able to replicate this performance. So it was quite encouraging results, although the numbers of patients in each cohort was quite low. And therefore, the predictive values also were in line with what we were expecting, and suggesting that this test might be useful for patients with indeterminate thyroid nodules. Then we performed two multi-center trials in the US and Chile to determine the performance in a large scale of different sites and patients. And what I'm showing here is the gene expression profile of the gene signature, which is basically composed of tumor microenvironment biomarkers and epithelial biomarkers. You'll notice that BRAF or mutations are not included in this classifier, which is a question we get frequently. However, this classifier is based on the different approach rather than mutation. It looks or interrogates the differential expression for biomarkers that are associated to inflammation and epithelial cell development. So as this clinical validation, as I mentioned, was two independent trials. And you can see that the sensitivity and specificity for the Chilean trial, which was at 150 to 55 patients, showed to a 90% sensitivity and an 89% specificity with an MPV of 96. And the US trial showed a 91 sensitivity and 87 specificity and an MPV of 94. Just keep in mind that the disease prevalence in the US cohort was very high, which impacted the MPV. So basically, since there was no statistical difference between these two trials, we pooled them in one single cohort of 270 patients, which is the largest study that has ever been published, showing a consolidated sensitivity of 91 and 88% and specificity respectively, with an MPV of 95 and a PPV of 78. When we looked at the different subtypes of tumors, in the upper part of this table, you see mostly the benign cases or non-surgical cases, and you can see that most of the nodules that were benign were correctly called benign in an average of 80%, which is in line with the specificity of the test. And for a broad range of malignant tumors, which we see very frequently in indeterminate nodules, also we had a very high rate of detection, all in the range of 90% sensitivity. We did include a set of medullary thyroid cancers that were not originally detected as indeterminate, but we just wanted to have a sense of how this test was performing and how it classifies medullary carcinomas, and it showed that all these tumors were classified as malignant. So after the development work and then the validation work, the next question was, well, is this test actually useful or clinically useful? So we just had a paper accepted in endocrine-related cancer a week ago. This is a single site study in our institution. It was in a real world setting where physicians were allowed to decide whether or not to use molecular testing based on their clinical findings. So in a period of 18 months, we collected 1,200 FNAs, consecutive FNAs, of which 19% were classified as indeterminate. Almost 50% were Bethesda 3 and Bethesda 4. In 2/3 of the patients, the thyroid test was requested, and of these patients, 7 patients had an insufficient sample, and so this was repeated. And the rest of the patients, the 36% of patients, physicians decided that with the clinical information they had, they felt comfortable to follow through their recommendation. So in this group, that non-tested group, a third of them had no surgery and went to follow-up because they had low-risk ultrasound, small nodules, and most of them were Bethesda 3 with no nuclear atypia. And then 2/3 of the patients underwent surgery, diagnostic surgery, and of this group, 32% ultimately had a malignant nodule. In the patients that underwent testing, 2/3 were called benign, and with an 18-month follow-up, only 1 patient had undergone surgery because of growth of the nodule, and 99% still are under follow-up. And of this patient that underwent surgery, it came back as benign. So the benign call rate of the test ended up showing to be 67% of all indeterminate patients. In the suspicious group, all patients underwent surgery, and the malignant rate was 71%. So you can see, although these are not comparable cohorts because it's not a randomized trial, and there's selection bias, you can still see that there's a trend to enrich the group of malignant cases that undergo surgery in the tested group, and there's a very meaningful group of patients that are able to avoid diagnostic surgery. So in a more illustrative way, if these were patients that were going to be sent to diagnostic surgery, you would expect that with testing, about 2/3 of these patients would avoid this procedure in a safe way. So our current clinical practice workflow is that when a patient undergoes a fine needle aspiration and indeterminate cytology is reported, we go back to the ultrasound to reevaluate the ultrasound risk. And if the patient has a high-risk, suspicious ultrasound, we tend to recommend direct surgery because we anticipate the pretest probability is very high, and molecular testing will not provide additional value for the diagnosis. Alternatively, if the patient has a very low-risk ultrasound, we tend to, and a Bethesda 3 with no nuclear atypia, we tend to recommend follow-up or maybe a repeat FNA. So it is for those intermediate risk patients with Bethesda 4s and Bethesda 3s with nuclear atypia where we feel that molecular testing has more value. And we do consider, obviously, in addition to the ultrasound risk, we do also think about and consider the patient's status, performance, and preferences, because obviously there are some patients where they may have underlying severe disease where the thyroid nodule is a secondary importance, and spending money on molecular testing doesn't actually move the needle in terms of the overall performance of the patient ultimately. So it's not, we do not recommend molecular testing to all patients with indeterminate nodules. It should be an aid for the physician to find the best possible recommendation. And this is just another tool to offer the best possible treatment. So just to finalize a few cases, this is a 59-year-old male with a 1.2 centimeter left-sided nodule that came back as a Bethesda 3 with no nuclear atypia. So the options with this patient was surveillance, a repeat FNA, molecular testing, or a lobectomy. The physician recommendation was molecular testing, and the patient's choice. The patient was agreed with this approach, and the thyroid score came back as benign and has been undergoing follow-up for the last 24 months. This is a second patient, a 38-year-old female, in follow-up for colon cancer that was undergoing a PET-CT for follow-up, and a incidentaloma came back in the thyroid, the right thyroid lobe with an SUV of greater than 20. FNA was performed. It came back as suspicious for follicular neoplasm, and you can see this nodule here, which is heterogeneous, no microcalcifications, and good smooth borders. However, when we looked at the options that were limited to molecular testing and surgery, our personal preference was surgery, given that the SUV was greater than 20 and it had an intermediate risk ultrasound. However, the patient preference was molecular testing. She wanted to avoid surgery at all costs. So she underwent testing, and the score came back as high. Lobectomy was performed, and the path came back as usual or conventional type PTC. And this third group patients is a 47-year-old female with a 2.4 centimeter nodule with Bethesda 3 with architectural atypia, pretty similar to the first one, where repeat FNA, molecular testing, or lobectomy were the options. Molecular testing was agreed with the patient and came back as benign, and again, more than 30 months in follow-up with no changes in the nodule so far. And this final nodule, which is a 1.6 centimeter right-sided nodule, which came back as suspicious. In our opinion, very high-risk nodule, heterogeneous, hypoechoic, and irregular borders. And our recommendation was direct surgery. Again, the patient wanted to explore all options in order to avoid surgery, which ultimately the thyroid score came back as malignant, and the report was PTC usual variant. So just as a corollary, our recommendation, we feel that molecular testing has provided value to our practice. We recommend selecting the patients carefully, having a deep conversation of the pros and cons of the test. And what we routinely do is that for patients that qualify within our criteria, we offer this test. And most patients tend to accept the test. And those patients that come back suspicious, only few of them undergo downstream BRAF testing or others, which I personally feel that does not have any value for surgical decision. It might have for further follow-up, but that could be performed after surgery and does not have to increase the cost of testing prior to surgery. Thank you again for the invitation.
Thank you very much, Hernan. That's great talk. Ian, do you have any questions?
Okay, yeah. How long we got? Hernan, is Ian Nixon here. Apologies in advance for not opening your study in our hospital. So we've got some questions from the I think this is from the online system. How long do you follow these up if you get a negative test? Is it lifelong follow-up for these nodules?
Yes, yes, we follow them as if they were Bethesda 2, just because of potential growth. And so we're not concerned about the potential malignancy. And yes, there is a residual group of patients that may have a low-grade tumor or a minimally invasive follicular cancer, because there is a risk of a false negative. But it's pretty well accepted that these tests have at least have less than 3 to 4% residual malignancy rate, and with a yearly follow-up with ultrasound, we already have patients that have 4-year follow-up with no changes in the size of the nodule, and it's actually shown to be quite safe. But we do follow them permanently.
A few people in the audience were involved in writing the kind of UK we call it NICE guidelines, where I think we felt that if your negative predictive value was less than 95%, we wanted 2 assessments before hopefully discharging a patient.
Right.
Thinking about how we might put this into practice in the UK, because I'm sure it's coming as you drive down the price. And so you have your 1 moment assessment where you say they're intermediate, you do your molecular testing, it's low risk. You then reassess them. Presumably they remain a Thyroid's intermediate risk ultrasound, I guess. Do you then go through that entire process again, FNA, and if that's Bethesda 3-4, molecular test again?
No, only if there's a meaningful change. So let's say there's a 2-centimeter intermediate risk nodule, low risk molecular test. We follow with a yearly ultrasound, and if there's a change from 2 to 3 centimeters because it just grew, because it was a follicular hyperplasia or adenoma, and there's the clinical judgment lies around the growth of the nodule and not the biology of the nodule. Now, it is, and you may correct me here, my impression is that usually nodules don't change in their pathology. They may grow, but they start as adenoma and they follow as adenomas, and sometimes they move towards invasive, but usually there's not a significant change. So we don't perform repeat FNAs unless there's a meaningful clinical change.
Okay, maybe one last question. I'm sure Jay knows the answer here, but does size matter? If you stick a needle in one part of a nodule and then in another, do you get different molecular tests because of nodular heterogeneity?
That's a great question. So within the analytical validation of this test, what we did is this was performed in the operating room, though, because you can't do this with a patient. We collected samples, independent samples from large nodules of the same nodule. So we looked at intranodule variability, and the consistency of the result was 100%. So we never had a case where you had 2 needle sticks which were benign and then 1 needle stick which was malignant. So there's quite good consistency in larger nodules, and that heterogeneity does not impact, or has not shown to impact the clinical credibility of the FNA or the molecular testing through FNA.
Thank you very much. Omar Hilmi here now. Slightly different question, but related. We do occasionally see follicular neoplasms of unknown malignant potential on the final pathology. Do you see that? And could we use this test to define the malignancy in that, do you think?
Well, unfortunately, these unknown malignant potential tumors is something we only know ex vivo, and we're not able to determine their before surgery. So that's the first question. These tumors are experienced as they come back 50% malignant, 50% benign on most of the molecular tests. If you look at the Affirma test, the ThyroSeq test, and our test, the umps or FUMPs come back 50% on both sides. So I don't think it actually adds value to these particular tumors to perform it ex vivo. I think even for mutational analysis, we still need to know, based on prospective studies, how they will behave in terms of their true malignant potential, doing the molecular testing now and following them for 5 years. And that just then we'll know if any molecular testing helps us with these patients.
Thank you very much.
Brilliant. Thank you very much, Dr. Hernan. And there are a few more questions in the Q&A. You can actually type and answer live.
Sure.
Actually.
Okay,
And I
thank
think
you.
we're moving on to the next.